Bienvenue, je m'appelle Guillaume DeFoor. Je parle un petit peu de français. J'habitais à Paris il y a longtemps quand j'étais jeune, à l'école de médecin René Descartes à Paris. J'oublie beaucoup. On parle anglais, s'il vous plaît. So thank you very much for this opportunity. I wish I could give the whole talk in French. I would love to have that skill set still, but it's been a long time. I'm a pediatric urologist at Cincinnati Children's Hospital in Cincinnati, Ohio, and I am going to talk to you guys about some topics regarding bladder outlet obstruction and neonatal end-stage renal disease. Can everyone see my slides okay?
Yes.
Yes, it's okay.
Okay.
We're good.
Okay, so I would like for you to feel free to stop me at any time if you have any questions or if you want to discuss further a case or management. I would be happy to slow down and we can kind of go in detail on any kind of points. So this is where I'm from. I'm from the state of Kentucky, just south of Cincinnati, from a very small town of about 9,000 people. It's a very pretty area, horse country, rolling hills, and sort of green pastures. And that's where I grew up. I trained, I went to medical school there in Kentucky, where I'm from, and I trained in South Carolina and did a master's program in Boston. And like I said, I did a stage as a Fulbright fellow at the Université René Descartes in Paris back in the early 90s. And this is where I am now. This is Cincinnati Children's Hospital. I was a fellow till 2003 and then have been on staff since that time. And this is our main hospital here. This is the operating rooms and the intensive care units. And this is a research building, clinical research building. And these are sort of some other offices. And what you don't see is another $600 million building that's on the other side here that's been built since this picture was taken about 3 or 4 years ago. So I thought we would talk in the setting of 3 cases about neonatal end-stage renal disease from bladder outlet obstruction. And I'll talk a little bit about how things are managed in our fetal care center era, some topics and tips on postnatal management in a baby born with bladder outlet obstruction. When do we consider diversion? And then I've got a couple other cases that can illustrate some of those points. And then finally, we'll talk a little bit about preparing these babies for transplant, and then some of the aspects of lower urinary tract reconstruction, and then what to consider long-term as far as those babies who are augmented as far as malignancy risk. So again, please feel free to stop me at any time as we're going along. So the first case was a baby that was found to have prenatal concern for bladder outlet obstruction. The baby was referred from Houston, Texas. There was anhydramnios, no fluid around the baby, received a vesicoamniotic shunt at around 20 weeks, and then had some amnio infusions locally in Texas until the baby had premature rupture of membranes and was delivered at about 32 weeks gestation. The baby was very small, very sick, had pulmonary hypoplasia, as you can expect, and also had a chest tube. And they were then transferred to Cincinnati Children's for sort of further evaluation. Our initial testing included an ultrasound that showed a very small and dysplastic solitary left kidney, a distended bladder with a shunt that was malfunctioning. So the baby was unable to be catheterized at the bedside, so we had to take the baby to the operating room for a cystoscopy. And this showed urethral atresia, so a vesicostomy was performed. And as you can imagine from the indwelling VA shunt, the bladder was thick-walled, severely inflamed, lots of polyps, and we removed the shunt at the same time. The baby had bilateral non-palpable testicles and a prune belly type appearance to the abdominal wall from the distension. So the baby, despite having this well-draining vesicostomy, continued to have a rising creatinine. You can see kind of peaked around 7. The baby's serum sodium began to drop precipitously into the very dangerous range of about 117. The kidney remained very dysplastic appearing, but the ureter became very, very massively dilated. And at this point, the baby was overloaded fluid-wise, anuric, but was only about 1,600 grams, which in our institution, they need to be about 1,800 grams for peritoneal dialysis. So we had a meeting with the family and all the caregivers and basically said we didn't think there would be much we could do for them, but we opted to divert the ureter, thinking that maybe the hydronephrosis wasn't being sort of appreciated in the kidney because of fibrosis and dysplasia. And so there might have been a secondary ureterovesical junction obstruction. So we took the baby to the operating room and basically just made a window into this massively dilated ureter. And you can see the creatinine began to come down kind of slowly and then nadired around 1.9. And then later in the first year of life, around 5 months of age, when the baby was around 4 kilograms, then the baby ultimately required peritoneal dialysis. So we didn't have any expectation that the urinary diversion was going to save this baby's kidneys, but basically it served as a bridge to get the baby bigger to ultimately be able to perform dialysis. So next steps in this child, there's a lot of things going on. There's a solitary kidney with ureterostomy and a secondary obstruction. There's an intra-abdominal testicle. You have a dry bladder with a vesicostomy and then no outlet to the outside world. So there's a lot of work that needs to be done moving forward in this child. So to prepare a baby like this for transplant in the setting of urethral atresia, you can try to attempt a urethral rescue. We've been able to serially dilate these tiny atretic urethras over time and then start intermittent catheterization. We've had some where we've lost the urethra. The family had trouble passing the catheter or maybe made a false passage and then ultimately had to stick with the vesicostomy. When they have intra-abdominal testicles, we would prefer to do a 2-stage laparoscopic orchidopexy, particularly if we can get that done before they start peritoneal dialysis, because as you can imagine, the peritoneum becomes very thickened. It becomes very difficult to dissect out the testicle. But typically we found if you do a 2-stage orchidopexy, then you have a much better chance of salvaging the testicles. And then worst case, then you might have to transplant into the vesicostomy. At our institution, they have to be at least 10 kilograms by weight minimum. And then if they're not a baby who's already undergone peritoneal dialysis and their abdomen is not too stretched out, they need to be at least 82 centimeters is their current protocol. So in the fetal care center era, as you can imagine, this requires extensive prenatal counseling with multiple different services, pediatric urology, pediatric nephrology, the neonatal team, pediatric pulmonologists and cardiologists. So we have team meetings where we meet these families. It's a challenging journey. Early renal replacement therapy is often the case in these most severe patients, particularly the ones we call pulmonary survivors, where they've had amnio infusions to maintain the amniotic space. And then all of these patients need lifelong bladder management. So we optimize the pulmonary function with amnio infusions up to around 32 to 34 weeks. And we use what's called an amnio port to make it a little, to facilitate the infusions. We do not treat bilateral renal agenesis. We looked at our numbers, and after about 10 patients with bilateral renal agenesis, none survived past a few months of age. And so we basically feel this is a lethal defect. And so at this point, we are not offering any prenatal intervention for BRA. In the setting of severe oligo or amniohydramnios, where we feel there is some preservable renal function, then we will offer prenatal intervention, as such as perhaps a fetoscopic valve ablation. We will do fetoscopy up to 28 weeks. We did have a series of fetal vesicostomies, but the outcomes were poor, and the premature rupture of membranes and prenatal early term delivery was too high, and so we have stopped doing that. And typically, we need a birth plan in place. Sometimes they deliver inside our children's hospital. We have a birthing center, so the mother in the last few weeks before pregnancy can be delivered in our children's hospital, and so the baby can be sent right down to the NICU without having to be transported. So After birth, that's when us urologists usually get involved. We don't do a lot of the prenatal interventions. Our fetal care surgeons do those for the most part. But after birth, obviously, we get heavily involved, and immediate bladder drainage is obviously the rule. We, in sort of your more basic posturethral valve patients, and once they're stable and their creatinines have nadired, usually in the first week of life, we'll consider taking them to the operating room and doing a transurethral resection of the valve. Usually with a cold knife. I usually do 5 and 7, and then sometimes a cut at 12. We are trying to get pediatric pulmonology to kind of come in when we do these cases, so they can kind of evaluate the airway and the lungs, because a lot of these patients will have some chronic lung disease. And then we'll talk in a minute about when to divert these patients higher. And then, of course, you need supportive NICU care and nephrology consultation to monitor the upper urinary tracts and renal function and minimize urinary tract infections. So bladder function obviously is important. There's a lot written about avoiding a dry bladder, bladder cycling. We use a lot of if they are anuric or if they have they've been diverted. We'll use gentamicin bladder irrigations to cycle the bladder to get them ready for the transplant. We use a lot of clean intermittent catheterization in these patients to rehabilitate the bladder, particularly if they've been diverted. And then we use a lot of anticholinergic medication. So, and this is just an example of a very massively dilated posterior urethra with a terrible looking bladder and high-grade vesico-ureteral reflux before surgery. And then this is a few months after surgery. You can see a much improved dilatation of the posterior urethra, resolved reflux, and a much better looking bladder. So the bladder function obviously is important, but in this early era, particularly in these most severe cases, the worst of the worst, the renal function is more important. And so that's when we consider diversion to protect or prolong the native kidney function as absolutely long as we can possibly do. And then we'll worry about the bladder later. Any questions about the immediate postnatal management? So when do we consider more proactive management of the bladder or even urinary diversion? So typically in sort of the worst of the worst, and somebody's raising their hand. Dr. Sanfleur, do you have a question?
Yeah, I do. Hi, sorry, I did not present myself earlier. Dr. Kier. I was just wondering, because it went a little bit fast, what do you actually consider a dry bladder? Because you've been mentioning that a lot.
Yeah, and we'll talk about that in a minute when we talk about diversion. But when you have a baby that has that's maybe been diverted, or who is anuric and the bladder is not filling with sort of natural urine output, then we would consider that a dry bladder. And to get that bladder ready for transplant later, we would need to do some rehabilitation of that bladder. So dry bladder just means one that's been diverted, so no urine output is coming down into the native bladder.
Thank you.
So the baby's born, the baby has a catheter placed, and then maybe you decide to do your transurethral ablation of the valve. When would you then consider to be more proactive with the bladder management early on? In other words, when would you start something like, clean intermittent catheterization? So in the setting where maybe the renal function is worsening, the hydronephrosis is worsening, you have very, very severe vesico-ureteral reflux with reflux nephropathy, like in this setting, or a very markedly abnormal bladder. And again, these are sort of the worst patients. Then we might consider intermittent catheterization to drain the bladder at a low pressure, maybe start anticholinergic medications. Sometimes you'll have a very, very thick-walled bladder, and you can see almost like there's a secondary ureterovesical junction obstruction here, where the bladder is so dysfunctional and so thick-walled that the urine is just not passing through the ureter into the bladder. So in those settings, sometimes we can kind of help with the drainage of the kidneys by starting intermittent catheterization. when would we consider vesicostomy in the case before where there was urethral atresia and you couldn't reliably get into the bladder through the native urethra? And then there's some other rare situations of bladder outlet obstruction, like an anterior urethral diverticulum. Perhaps the baby is too small to safely allow the passage of a cystoscope. And our smallest infant resectoscope is 9 French. So sometimes that's a bit of a challenge to pass into the native urethra. So if they've had a catheter for a week or two, sometimes that helps. But if they're just too small and you can't pass the resectoscope, then sometimes the vesicostomy is safer. And then in that setting, like we talked about before, when you've already done your valve ablation and you feel like they need clean intermittent catheterization and you just can't get it done, like the urethra is too aberrant and you can't pass the catheter, or if the family just can't do it for whatever reason. In those settings, then we would consider a vesicostomy. And then when would you consider like a higher diversion, like a ureterostomy? And again, this is very rare. And so, this might be once every 2 or 3 years or so, in sort of in a typical practice. We tend to have several of these around at any one time. But basically, this is when you feel like there's a secondary ureterovesical junction obstruction, maybe with a very tortuous ureter and a thickened bladder wall. And again, you've drained the bladder. And sometimes this is done before you do the valve ablation. So you have the catheter in, you're draining the bladder's empty, and the hydronephrosis and the renal function is worsening, like I was showing in that first case. And you can always consider a percutaneous nephrostomy just as a temporizing measure, or maybe to give some time to maybe to get the bladder to maybe you have time to respond to oxybutynin or anticholinergic medication. The problem with a nephrostomy is that at some point you're going to need more definitive diversion if the drainage doesn't improve. And so you can certainly consider a nephrostomy if you want to, if you're not sure that they're going to need it long term, or if you just want to see if the renal function will improve with proximal drainage. So typically for ureterostomies, we do them low, actually. We do low end cutaneous ureterostomies through a little fan and steel. And you can usually dissect probably 8 to 10 or more centimeters of the ureter to stretch it out and bring it out in a kind of in a smooth curve out to the abdominal wall. We used to do them high up proximal ureterostomies, but that tends to be very difficult for the family to manage. The urine is draining up high in the flank. They usually have to wear a double diaper around their abdomen. And so we tend to do more low-end cutaneous ureterostomies nowadays. And so that'll be illustrated in this next case. So this is another case of bladder outlet obstruction with anhydramnios. You can see a distended bladder on this T2 weighted fetal MRI. There's a dilated posterior urethra with bilateral hydroureteronephrosis. The baby actually ended up making it to near term at 36 weeks. I believe that anhydramnios developed kind of late, and that's when they delivered the baby. And so you can see the initial ultrasound. There's some echogenic renal parenchyma with sort of moderate to severe hydronephrosis. And then the bladder was really thick-walled and decompressed after we were able to place a catheter through the native urethra. So this is the initial VCG. This is what we showed a little bit earlier. So this is the bladder, very trabeculated with high-grade vesicoureteral reflux with maybe some distal narrowing of the ureters here. This is the posterior urethra, and you can see where the valve is right here. Very abnormal looking bladder. This was the initial VCG. So despite having the bladder drained, this is again a case where the serum creatinine continued to rise to about 2.7. And at that point, we did decide to do bilateral nephrostomies, and the creatinine came down nicely. And then we decided that we were going to convert the nephrostomies to ureterostomies. And then the creatinine continued to decrease. And in the within a couple months was down actually within the normal range for his age. This is kind of what they look like. So this is the umbilicus. This is a low fan and steel incision. You can see the cutaneous ureterostomies are on either side of the incision. The kidneys responded quite nicely, still a bit echogenic, but the much more decompressed than they were. And like I said, clinically, he was doing very, very well. This was a family that was very motivated. The mother is actually a physical therapist at our institution. And so we started, again, this was a dry bladder as the baby had bilateral cutaneous ureterostomies. So we started bladder cycling and oxybutynin and got the capacity up quite nicely to about 100 milliliters. So around age 1, we took the baby back to the OR, did a valve ablation, urinary undiversion, and bilateral reimplant. And we continued the intermittent catheterization going for another few months until the parents basically told us the baby was peeing nicely between catheterizations and there were minimal residuals. So then we weaned everything off. So the baby actually did very well for about 18 months or so. And then just recently, actually, last fall, unexpectedly on an ultrasound, the kidney started to look kind of blown back out with now more severe hydronephrosis. And this was after an ultrasound 3 months prior that had been pretty stable. The creatinine was up a little bit. The baby was otherwise asymptomatic, but she did notice that there was a very high overnight urine output, and this seemed to be a change. And so, maybe there was a little bit of diabetes insipidus and nephropathy going on with an increased urine output, but the baby otherwise seemed asymptomatic. So we started with an alpha blocker, tamsulosin, and then repeated the ultrasound about a month later. There really wasn't any change. So then we went back to intermittent catheterization and overnight catheter. Of course, he's now age 3, so he absolutely hated it and kind of fought them, but they kind of fought through it, and now he's doing much better. I saw him in January. His hydronephrosis had decreased. You can see now a little bit less prominent. The creatinine was down a little bit, and his GFR was in the chronic kidney disease stage 3 range. We did urodynamics at this point, and you can see the detrusor pressure on this third channel. There was a lot of instability here. He did actually hold a fair amount. For his weight, we would expect about 100. He was about 13 kilograms, so we expected about 100 milliliters. So his functional capacity was just under that. So in this setting, we would start back anticholinergic medication to kind of dampen this instability and improve the compliance. And so, so now he's on oxybutynin, 1 milligram 3 times daily. He's now dry between catheterization, and his volumes have increased rather considerably. And he was having some side effects when we tried to go up a little bit more. So he's kind of stable now at 1 milligram. And you can see the kidneys don't look great, fairly echogenic, but at least they're draining fairly well and the less hydronephrosis. Any questions about this case? So this was a case, again, of bilateral secondary ureterovesical junction obstructions from a bladder outlet obstruction, and then how to manage that afterwards and with the dry bladder. Any questions about this one? Okay, and so the third and final case, okay.
Excuse me, yes. I have a question.
Sure. Yeah.
Yes, about this case, when did you decide to do the ureterostomy instead of leaving the vesicostomy?
So for this one, the vesicostomy we didn't consider because the bladder was drained and the creatinine kept rising. So in this setting, vesicostomy would probably not have been of much benefit, because he had bilateral ureterovesical junction obstructions, and so he needed a higher diversion. Does that make sense?
Understand. Yeah, yes, okay. Thank you. Another question. Yeah. Is there any particular case where you decide to go directly to the bilateral ureterostomy instead of going first through the vesicostomy?
Yeah, so that's a good question. So if the so like in this setting, we never did a vesicostomy because the bladder was drained well with the catheter in the urethra. So if in the very first case, that was urethral atresia, then we had to do a vesicostomy because there was no way out through the native urethra. And so we had to do the vesicostomy first. But if the bladder is drained well and there's still a rising creatinine or worsening hydroureteronephrosis, then that would be when I would, in that rare situation, then that's when I would consider a ureterostomy or a nephrostomy.
Thank you.
Professor, do you think that double G stent can help in that case?
Yeah. So that's a great question. The problem, I think it would be a little tricky getting the wire and the stent up this very tortuous ureter, and I guess you could make an argument you wouldn't need it to be all the way in the kidney. But yeah, I think that could be possible. But again, I'm not sure what your endpoint would be there. I guess you could put them in and then see if the bladder wall thickening improved with oxybutynin. But yeah, I have not tried that yet. I think it would be in a little bitty baby. I think that would be a little bit of a challenge. And you're talking about that instead of a nephrostomy, is that correct? All right. Any other questions about this case?
Yes. Another question.
Yes, sir.
Yeah. Do you think that surgery to increase the bladder capacity in this stage? What do you think about to increase the bladder capacity?
Yeah, so in this case, the family increased the bladder capacity quite nicely with bladder cycling and anticholinergic medication. So we usually use gentamicin irrigations to expand the bladder, and we'll start very small, like maybe 3 milliliters or 5 milliliters, 3 or 4 times a day, to get the child used to passing the catheter, and also to kind of try to stretch out the bladder. And then we'll increase that slowly every week, try to increase a few milliliters. And like I said, this one increased quite nicely up to almost 100 milliliters. And that took about 3 or 4 months. So sometimes we're under the gun. In other words, like if the baby's kidneys have failed and they need to get a transplant, or they're heading towards dialysis, sometimes we don't have enough time to cycle the bladder, because this is a project that takes several months. And again, a very motivated family with a lot of resources and time to do it. And so again, it's a difficult plan of care, and not every family has the time or the ability or the resources to do it. So it is a lot of work. And so again, this was a family that really was wanting to do it. And we were able to get the bladder stretched out.
I have one last question, if you allow me.
Yes, sir.
Thank you. On a general basis, do you recommend to perform the ablation of the valve concomitantly with the vesicostomy or the bilateral ureterostomy?
Yeah, great question, actually. And I would say no, I would leave it alone, because then if there's no urine passing through the posterior urethra, I would worry about scar tissue. So if it's going to be a dry bladder, now that said, I might sometimes go back and ablate the valve if they're having a hard time doing intermittent catheterization. But usually if I'm going to divert, then we leave the valve there until it's time to undivert.
Thank you.
So this is just one last quick case, and this is a baby who has bilateral multicystic dysplastic kidneys with anuria throughout pregnancy. And you can see on this fetal MRI, large cystic kidneys bilaterally. So there really was no role for diversion or any sort of prenatal intervention here other than amnio infusion. This is kind of what the kidneys look like postnatally, as you can imagine, large, multicystic. So this baby immediately needed dialysis. And so they would start hemodialysis until the peritoneal dialysis catheter was matured. And then they could start peritoneal dialysis. So when you have a baby like this, who has either bilateral renal agenesis or bilateral multicystic dysplastic kidney, at some point they're going to need a transplant. And so that's when we would become more back involved in the care of the baby. And again, they need to be at least 10 kilograms weight or 82 centimeter and or 82 centimeters in length. And so we would start with just the usual testing, VCUG, we might do a cystoscopy or dynamics, maybe try bladder cycling. And in this setting, there was no bladder outlet obstruction. The bladder, it's really unknown whether there's going to be functioning bladder tissue there. So that's a real unknown, but we can try cycling. If we are not successful, then sometimes we'll create a vesicostomy before transplant, let that heal, and then transplant into the bladder drained by the vesicostomy. Now, if there's no bladder or the bladder is just, less than 5-10 milliliters, and you can't even mature a vesicostomy, then we'll bring the transplant out as a ureterostomy as the last resort. This is not ideal, and urinary tract infections are a problem. Getting urine specimens is a problem, and obviously having the kidney draining right out to the abdominal wall is not great. But if the baby is not doing well on dialysis and they need a transplant, then that sometimes is the way we have to go. So that concludes the three cases. So the very last few minutes, I was going to talk a little bit about what we do to get the bladder ready surgically, for transplant if it's necessary. So the last few slides, I'll just talk a little bit about our bladder reconstruction kind of program. Typically, we would do this when the child is a little bit older, maybe child is in school age or ready to be out of diapers. And as you all know, these are major abdominal procedures. We will sometimes use gastric segments, but often we, do your typical ileal bladder augment, and that requires, a small bowel anastomosis. Usually they're in the hospital for a week or two. And by this point, they're probably immunosuppressed with a transplant. And then again, if you're going to make someone continent with a neobladder, and this is a gastric ileal neobladder with a appendiceal Mitrofanov, then you really need to make sure the family is compliant and going to do what you ask them to do, because if they don't catheterize, then that can be a disaster, as you probably all know. The Mitrofanov, I'm sure everyone here is familiar with this. Basically, we use the appendix, harvest it from the cecum, maintain it on its blood supply, and then we do an extravesical tunneled anastomosis extravesically for the most part, and that forms sort of a one-way valve to keep it dry. And then if the appendix is not available or not suitable, then we can reconfigure ileum. That's a Monty Mitrofanov. Sometimes we split the appendix with the colorectal surgeons to do a concomitant ACE or Malone. And then really rarely, if you have the tissue, you can use the ureter, but that's almost never available. So, and then this is an example of a Monty Mitrofanov. So this is reconfigured ileum. Which the nice thing about that is the pedicle is right here in the middle. We use non-tooth bowel clamps to make the tissue nice and tight. And then we do a Parker Kerr stitch across the top here. And then that leaves a nice straight tunnel or channel that's without any sort of tortuosity to it. And then we usually bring the Mitrofanovs wherever they want to come out to, which is typically the right lower quadrant. We usually don't try to stretch them out to the umbilicus, but there's a lot of centers that try to do that. And I don't have a problem with that. It's just sometimes the Mitrofanov just, we just kind of see where it wants to come out of the abdominal wall. And usually the the best exit is in the right lower quadrant. And then if they need a continence procedure, which is a little unusual, which would be rare in sort of a valve patient, actually, we do what's called a modified Young's Ledbetter. So we excise, so we've got the bladder wide open, you've got ureteral catheters in bilaterally. We excise a little triangle of mucosa, and then we tubularize this sort of back wall of the bladder neck over a 8-French catheter, and then close the muscle over that in a few layers. Then we dissect a plane behind the urethra, and this is a little Penrose drain, and then we harvest a little bit of fascia and bring that out underneath the reconstructed bladder neck as a urethral sling for more continence. But again, that would be a little bit unusual in the bladder outlet obstruction kind of patients. So now the very last segment, this is just the last couple slides about malignancy, especially when you're using combination segments, like this is gastric tissue and ileal tissue and a neobladder. The literature is very bad in pediatric urology as far as this is concerned, but it seems to be about 6% cumulative incidence over time, maybe a bit higher in the gastric augments. And then there's a latent time of well over a decade. So, you know, there's a lot of controversy about whether these patients should be followed with surveillance cystoscopies. There's really not any other great markers. There are some few studies that compared patients with augments to patients with neurogenic bladder alone on a catheter program. There didn't see much statistical differences in cancer risks. And this was in an extrophy patient population, not a posterior urethral valve population. And as you all know, the valve bladder patients, you may have heard that term, and that's where you start with a really small, hostile, you know, high pressure bladder, and over time it kind of stretches out to a big floppy, poorly emptying bladder in sort of adolescence. And so typically it would be rare for us to have to augment a valve bladder unless it was very early and the bladder was just way too hostile and not manageable with anticholinergics or Botox. What are the risk factors for malignancy? Again, unknown, but theoretical, maybe poor drainage, stasis, pH changes, chronic infections, bladder stones, like you can see here, chronic indwelling catheters. And there's really no data on patients who have an augment or reconstructed bladder and a renal transplant. We just don't have good data for that. So, and I think that's pretty much it. So, you know, as I've shown with some of these challenging cases, fetal end-stage renal disease is difficult. Again, bladder dysfunction is universal, and you know, we worry about diverting the bladder and making it a dry bladder, but having an unobstructed draining kidney is the more critical point, at least early in infancy. And like I said, ureterostomy, no one is saying that that's going to save the kidney, but it could be a bridge to dialysis at an older age when it's safer. And again, having some urine output is easier for the nephrologist to manage than if there's no urine output. And sometimes when a patient has some urine output from a ureterostomy and they're on dialysis, like peritoneal dialysis, if they need some sort of intra-abdominal procedure like a gastrostomy or an intra-abdominal laparoscopic orchidopexy, they can hold the PD for a couple of days, and the urine output will kind of let them limp along without doing hemodialysis in the meantime until the peritoneum is rehealed. So it's better to have some urine output than no urine output, of course, even on dialysis. So, and all these patients that are most severely affected from a kidney standpoint also have really severe bladder dysfunction. Catheterization programs are pretty ubiquitous in our practice on these patients. And then we will consider diversion if they're unable to perform CIC. And then finally, for the transplant drainage, you want a low pressure bladder that empties completely. We try to rehabilitate bladders, cycle bladders, but if there's time pressure to place the graft, or if it's just not going to happen with a family, then a vesicostomy or ureterostomy is the last resort. And so, and again, just to kind of not to belabor the point, but the bladder function effects are sort of unclear after diversion. Regardless, most valve patients need active bladder management, regardless of how they're treated initially. We are advocates of aggressive and early intermittent catheterization anticholinergics, and that is to try to progress or limit that progression of bladder failure to that myogenic failure that they get sometimes as teenagers. And then, like I mentioned before, we will reconstruct bladders if indicated, with channels, augments, neobladders if needed. And then the malignancy risk is probably increased. So lifelong surveillance and transition to our adult colleagues as they reach adulthood is necessary to make sure that these kids are kept are monitored. So, and I think that is it. So I'm happy to entertain any questions at this point. And I thank you for your attention and your questions. And I will see if I can, Ashley, if I can stop sharing. I'm not sure how to do that. Do you know, Ashley, how to stop the
I'm trying to maybe
Oh, here we go. Stop share. It's a little red button. There we go. Good. All right, great. So hopefully that was not too much information in a short amount of time.
Dr. Brutus, it's good to see you. Well, thank you, Dr. DeFoor. I'll give the floor to whoever has questions, but that was an excellent lecture.
Oh, thank you.
I got one question for you, Dr. DeFoor. First of all, I would like to thank you for this brilliant presentation that you did. We learned a lot, but I would like to ask you something. What is the life expectancy for those kind of patients when you treat them? Most of the time, how long they live after?
How long do they live after?
Yeah.
Yeah, that's a great question. And I think we ask that question a lot. I mean, are we doing all these interventions and then the babies don't survive? And so I think that's why looking at our data for the bilateral renal agenesis was important, because those babies had lots of interventions, early dialysis, lots of procedures, lots of painful tests and blood draws and their short lives, and none of them survived. And the longest that any of those lived was just a few months. And so that's when we made the decision that if there's no renal tissue on the fetal MRI, then we're just going to offer supportive hospice care only and not aggressive intervention. Now, if there's some renal tissue, they'll, like the bilateral MCDKs, as you know, probably don't have much functioning renal tissue, but if there's some semblance of a kidney there, they'll tend to offer intervention. But if there's no kidneys, then they don't, then we don't put them through any intervention. But as far as the valve kids are I have valve kids that are well into their teenager years now and older. So yeah, so I think the overall the mortality is low.
I got another thing that I would like to point out. Most of the time when I do the treatment of my posterior urethral valve patient, most of the time I'm not really satisfied with the outcome, because we still have the dilated ureter and everything. I remember one day Dr. DeVries told me it's a legacy patient. So it's a patient that you're gonna do things lifetime. I don't know, what do you think about that?
Yeah, so it is very challenging to do a valve ablation in a little baby. Particularly if the instrumentation, only goes so small. And so if I feel like I did not get a complete resection on a valve ablation, I don't have a problem taking it back to the operating room and taking another look. And you know, especially if the hydronephrosis is not improving or their renal function is not getting better, and I don't think there's a secondary ureterovesical junction obstruction. So I don't have a problem taking them back for a second look, you know, maybe down the road a little bit if I'm not sure I got a good resection the first time. And often you'll find residual valves. So it's not uncommon when they're so little to, you can sort of mostly unobstruct them, but sometimes there's still some valve leaflets left. And that's why I always look at, you know, initially sort of 5 o'clock and 7 o'clock and engage the tissue and resect with a cold knife. And then I usually try to go right at 12 o'clock one more time. And I typically leave a catheter in just overnight, as long as there's not a lot of bleeding, and then see if they can urinate. And if not, you know, or if there's a problem, then we might start CIC.
Yuri,
Yes.
if I may, doctor, I think that in the cases that you are talking about, I'm not sure it is the ablation of the valve that would be the problem. It might be the type of diversion that we usually use. What do you think, Yuri? Hello?
I don't really understand what you said.
No, what I mean is that I don't doubt the quality of the resection of the valve. I'm sure that the resection of the valve is usually complete. But the reason why the patient does not improve, or if the ureteral dilation increases, might be because of the type of diversion what we usually use in these cases. What do you think? We don't do. Do you happen to do high diversion like ureterostomy, vesicostomy? I don't know. Tell me.
No. We never did that.
That's it. That might be the cases. What do you think, doctor? Hello.
May I, please? Thanks, Dr. DeFoor, for your talk. It was very interesting, very excellent. And thinking about the question of Yuri, I would like to know the babies that, for them with PUV, like, what is the early age for the surgery? Because here in Haiti, maybe one of the points which can explain the problem with the infants that we have here in Haiti. Usually they came later, and they already have much
damage, much renal damage.
Yeah,
Yeah.
Catastrophic hydroureteral hydronephrosis. So maybe
they present late. Is that what I'm hearing? They present like
they present late. Yeah, sometimes the diagnosis also some of them, in my experience, they had a previous ultrasound, and the conclusion was polycystic kidney disease or something that's not related to the real problem of the patient. So they go, sometimes we assist to medical shopping. They go to one center, to another one, and usually they came very late. Last week, I received a patient. He was, maybe you won't believe that. He is 5 years old. And it was the first time that I explained to the parents what is the problem of PUV. Yeah. And when we insert the Foley, we remove 1 liter in the bladder.
Yeah.
You understand? So I think that Yuri and the other, our urologist.
Yeah, those are tough where they miss the diagnosis or they misinterpret the prenatal ultrasound. And also if you're in a community where they don't do a lot of prenatal ultrasounds, you know, then they might present later with urinary tract infections or failure to thrive or renal failure. So those are tough cases. And I have had some that presented late, you know, with sepsis or with failure to thrive.
Yeah.
And those are challenging because by then, a lot of times the kidney damage is done.
Yeah.
Yes.
And sometimes they don't have the money neither, Bernard. The money to, that's another point.
Yeah.
That's another big issue.
Yeah.
Indeed. But tell me, doctor, in those cases where the child is very, it's no more an infant, is 4 or 5 years old, would not it be better to have directly a high diversion like a ureterostomy?
In a 5-year-old?
Yeah.
I think that would be a challenge to manage. You know, the high diversions in the flank, they're very messy and it's very difficult to collect the urine there. The lower diversion is usually a little easier for the parents. You know, the diaper can kind of collect it a little better, and you can stretch out a very tortuous ureter, you know, 8 to 10, 12 centimeters outside the incision, and then resect all of that redundancy and then mature your stoma low, and you can get a pretty direct drainage, you know, even when a ureter is really tortuous. So yeah, I usually vote for a lower diversion in that setting. And then when it comes time to reimplant, when you have the bladder managed, usually there's enough redundancy still to get in, and you can do a non-papered, you know, reimplant, and you still have enough ability to get it down. So.
Okay, thank you.
Yeah.
Thank you.
And else. Yuri?
I think for me, I'm good. I don't know if the other doctors like Dr. Tugal or other doctors want to say something. But for me, I'm good.
Well, I really appreciate talking to you. I would love to see your center sometime. I know there's a lot of challenges right now, and it's easy for me to kind of present things from our perspective, and I don't have much perspective on, you know, how challenging it is from your end, and so I'd love to learn more about how things work there sometime.
Well, we have to wait for better times in the country.
Yeah.
Because we are living in some dire situation down there. But hopefully we are not far from the end of it. Anyways, thank you so very much, Doctor. It was a very nice presentation. I think, I don't know for the others, but I think I learned a lot about the diversion, the timing of the diversion, the timing of the diversion versus the ablation of the valve. And I think I got something. Thank you so very much.
Well, you're very welcome. Thanks for having me.
Yes, thank you, Dr. DeFoor and Dr. Yuri, Dr. Brutus. Thank you for helping coordinate. It's good to see everyone, and I hope you all have a good evening.
Have a good night.
Bye-bye. Thank you.
Thank you.
Until next time. Thank you so very much.
It was
Thank you.